Good evening, everybody. Hopefully you can hear me okay. Thank you so much for joining our COVID-19 briefing webinar. It's one of many in a series we've been having. We usually hold these once a month. So thank you so much for everybody who's tuned in, and I imagine more people will be joining us as the evening goes on. So I know everyone has a very busy set schedule, and we're very happy to speak about this important topic. Next slide, please. Before we get started, I just wanted to quickly introduce myself as well as my colleague, Dr. Mirani. So I'm Dr. Karachiwala. I'm one of the Associate Medical Officers of Health for York Region Public Health, currently supporting the communicable disease file, so all things sort of COVID related. Like I said, we tend to hold these briefings once a month. I believe I presented on the last one. And then my colleague, Dr. Mirani, who's also joining today, which is great to have her. She is also online and will be helping out with the latter half of the presentation. She's a practicing family physician and also helping us here in public health, predominantly on our schools portfolio and getting involved in various things. And as usual, a big thank you to our corporate communications team and our general communications team who made this webinar possible. This will be recorded and posted on our health professional website as well, the link to which I will show in just a moment. And a big thank you to our sort of usual participants who helped put this webinar together. Thank you so much to our great team, and that includes Brooke, Emily, and Anastasia. Thank you. So as it says there, you will see that the meeting will be recorded. Next slide, please. The other thing we do is there is an ability to ask questions. And actually, I see a question that's come in already. We will be actually addressing that in one of the upcoming slides. So thank you for people who are starting to post there. That's great. We will monitor that throughout. It's called Live Event Q&A, as you can see on the screen. The participants can't see all of the questions, but we can see it, and myself and Dr. Mirani will be monitoring that throughout the presentation, just keeping an eye on it and try to answer things as we go. And if not, we've allocated a bit of time at the end as well to answer that. And what we usually do is if we completely don't get to anything or want a more detailed response given to you, we do send it after in a Q&A written format to send out to everybody too. So if you subscribe to our Public Health Matters newsletter, you will get it that way also. Next slide, please. So in terms of what we're going to go over today, quite a busy agenda, and we did allocate an hour this time instead of 45 minutes because obviously this is a very hot topic. So what we want to do is set the stage a little bit, talk about vaccine hesitancy, what the scene looks like, what we're seeing now in terms of operationalizing the rollout. I will say, just as a quick disclaimer, we have been having a series of meetings with our community providers who have been very helpful in terms of the rollout to long-term care and retirement homes. This specific webinar is not intended to go over the logistics of the rollout, operational aspects of it all. We do have another future webinar coming up about that. And so details around that will be shared shortly, and we had one in the not too long ago. But this is really to talk about communications issues, how to address vaccine hesitancy, and our goal here is really to equip providers who people hold in very high regard, a trusted provider in terms of a recommendation to get a vaccine or not. So to equip you with the common answers to questions that come up all the time, some plain language summaries that could be helpful for your patients, and really just address some of those constant sort of questions that keep coming up about safety and the rest that are really influential for vaccine hesitancy. So if there are questions around the operations, I'll do my best to address them, but that's really for a later subject and webinar. So you can see the outline of what we're going to be talking about today, and we can get right into it. So next slide, please. Alrighty, so why are we talking about this? Vaccines are one of our most important tools, particularly for COVID-19. This is going to be what we hope will be a huge game changer for the population in terms of establishing herd immunity and really slowing down infections and allowing people to return back to sort of some semblance of a normal life. But we know that uptake is very variable in the community, and vaccine hesitancy itself is a major issue. So you'll probably recall that the WHO actually called this issue of vaccine hesitancy out in its top 10 global health threats in 2019. And so really important to do a deep dive. Next slide, please. And I just want to acknowledge I am seeing some questions come up in the chat. We are going to talk about most of these in upcoming slides, so I'm monitoring as we go, but if I'm not addressing it right away, it's because we're going to talk about it very shortly. So, we put the slide up here to just make the point that a number of different sort of polls and studies have been done in terms of gauging what people are thinking when it comes to vaccine uptake across Canada and in Ontario as well. This is the result of an Angus Reid survey that was conducted in January, and it was Canada-wide. There was another global study that actually showed very similar results. So in general, we're seeing that about 2/3 of Canadians would accept a vaccine if it was available, and you can see that on the slide there. Good news is if you compare sort of November to now, the willingness of people to get the vaccine has gone up, which is very good news. There remains a portion of people who, are refusing vaccine and completely will not get it. But mostly these are sort of promising trends anyways. And it seems that when we look at the breakdown of ages and who's sort of more hesitant compared to others, it's that group of 35 to 54-year-olds that seem, at least from this opinion poll, to be most anxious to get it and where we saw the biggest change as well. Next slide, please. So, vaccine hesitancy is a result of a whole complex interplay of different factors. It's not necessarily just about individual beliefs, but we know that people's social circumstances, political circumstances, economic, etc., really shape that decision and how people frame it. And their social circle is a big influencer. What we do know is a provider's recommendation is excruciatingly important, and hence having this webinar focus on the community providers really being equipped to answer some of those questions and have those conversations. So when we look at studies that show why people might be hesitant when it comes to the COVID vaccine specifically, the major reason they tend to cite is concern around side effects. Other issues that come up include, wondering if it's actually going to be effective, and wondering if they themselves are actually at risk and therefore have any sort of benefit of getting this vaccine. This little Venn diagram on the side here is based on a WHO framework that just reminds us to think of all these different factors when it comes to hesitancy. So, people get complacent thinking they're not at risk. Confidence in the vaccine, whether it's going to work, whether it's safe, is a big reason. And then convenience plays a role. So is it actually accessible to everybody? That, of course, has to do with the rollout, but we are working very hard when we're planning our mass immunization clinics to really make sure it's accessible to all sorts of populations. People don't have to drive too far, and being mindful of different times of days, because we do have people that work many jobs and are not free during the day to get it. One thing I wanted to bring up is, some specific priority groups at times may be hesitant for different reasons. I heard an interesting tidbit from an Indigenous colleague the other day who mentioned to me that, as part of the vaccine, the provincial plan, Indigenous individuals both on and off reserve were mentioned as a priority group. And, this has to do with all sorts of reasons, more vulnerability oftentimes, and willingness of government. But when a lot of Indigenous people saw that, at least from this report of my one colleague, they were quite fearful, actually, because there is a long history of actually scientists and governments of experimenting on those populations. Similar things have been true for the Black population when you think of the Tuskegee experiments not too long ago. So there's a lot of historical reasons why some groups are maybe more hesitant than others, not all as a generalization or anything, but there are obviously political and historical factors and previous trauma and things like that that are very much at play. So I think we need to be mindful of some of those differences. Next slide, please. Okay, so a couple of things we wanted to make mention of. As I've said probably a couple times now, the recommendation from a healthcare provider is very critical. There's some really good studies that have showed this to be true, particularly when it comes to the recommendation around childhood immunizations, but we're extrapolating some of these findings to the COVID-19 vaccine uptake. I want to make the point that vaccine hesitancy is not the same thing as refusal. So in that previous diagram, you'll see that there's a small proportion of people who will sort of completely refuse. They're not on the fence as to they're deciding or not deciding, or may get it later compared to some people want to see what happens first. That's vaccine hesitancy. The flat out refusal is sort of a different category of people. And they tend to be the minority, which is good news. So what we're trying to focus on is those people in the middle who are the bulk of them. And that's what we mean by vaccine hesitancy. Some really good tips have been present in the literature. So oftentimes, and again, these come out of some research studies looking at the acceptance of childhood vaccinations and parents talking to healthcare providers about that. So often you're to present vaccine as the default approach, as like a blank recommendation for the population who don't have contraindications. Being honest about the side effects and honest about what we do know and what we don't know is really important, and that transparency people find, of course, very important, not feeling like you're being sort of misled or lied to. Stories can be helpful as well, and personal anecdotes. We tend to stick with facts and stuff as providers and professionals, but it is really important at times to tell a story, and that's what resonates with a lot of folks. Building trust, which often happens when you have a long-standing relationship with your client. Addressing pain, so not sort of skirting around the fact that it could be painful, and a common side effect is often pain at the injection site. And then focusing on individual benefit and community benefit. So one of the things that's a bit different with this vaccine, as I'll get into, is we don't know the effect on asymptomatic COVID infection and general transmission. So it's important to be clear about that. So we don't want to overemphasize that, the community benefit is great and it may stop transmission. Sure, we know people are protected from getting very sick from the vaccine. And we do know that a big impact too is on the actual acute care healthcare system. So framing it that way compared to just the effect on general transmission, which we don't really know, is quite important to be transparent about that. So next slide, please. Okay, so a quick update of where things are at. Again, I'm not going to spend too much time going into all the operations of things, but I do want to give a little bit of an overview. As you probably are aware of, this is the provincial plan in terms of the 3 different phases, and we're currently in phase 1, where the focus is essentially on congregate living settings for seniors, Indigenous populations, and of course healthcare workers, and that prioritization is ongoing. In Ontario as a whole, as of Friday, there have been about 190,000 doses administered to date. There is some, as you probably have read about in the news, some interruption to the Pfizer supply, but folks are kind of working around that and hoping that will get resolved soon. That's all sort of at higher levels of government than ourselves locally. But just so you know what's happening in York Region, we have delivered vaccine, Moderna, to all 28 long-term care homes in York Region. And we have about 75% uptake of all the residents in long-term care. So this is pretty good progress, and we are working our way through the vaccination of retirement home residents and staff and sort of essential visitors as well. So, and just to get a sense of numbers, in York Region, the population of retirement home residents is about 3,000, and roughly the same for long-term care residents. Alrighty. And on Friday, we will be delivering vaccine to Georgina Island, which is an on-reserve First Nations community. Okay, next slide, please. So again, not to get into too much of the operations, but you will know that these are the 2 vaccines approved and available in Canada. So we have Moderna and Pfizer, and there's some important differences between them and also some similarities. So of course, both are mRNA vaccines in terms of age of approval, Moderna is approved for those 18 years and older. Pfizer is 16 years and older. And we will be getting into the recommendations for subpopulations. So what about the adolescent years, you may ask? We will be getting into that. Both are 2-dose regimes, both are IM injections, and there are differences in terms of cold chain maintenance and storage. Next slide, please. A very quick note, because people are probably hearing a bit less about this one, but the Johnson & Johnson one has been a very promising candidate and has been in the news more recently as well. So people are thinking that, of course, by the time there's phase 3, we'll probably have, with our mass immunization for the population, we'll probably have a range of vaccine products available. This looks like it might be the next one in line for Health Canada approval, but more studies are coming out. So unlike the Pfizer and Moderna, it is not an mRNA, it's a recombinant adenovirus vector delivering sort of the genetic code for the spike protein through this adenovirus. It has been studied on people 18 to 55 and then those 65 and above. And like the Moderna and Pfizer, has really good endpoint results in terms of over 90% effective. The kind of game-changing thing about this one, of course, is that it could be a 1-dose regime. Right now, there are trials underway to look at whether a 1-dose versus a 2-dose is better, because there might be some boosting effect from a second dose. But those results, I believe, should be available, from what I'm hearing, sort of end of January, start of February. But if it is found that the 1-dose is quite effective, that, of course, will be huge for operations and rollout. It is showing to be quite stable in terms of the duration of the immune response, and sort of looking at it from like 57 days out and beyond that. Similar sort of safety profile to the other ones, fever being the most frequent adverse events. And the other really good thing about this one is, of course, the cold storage requirements. So it actually stays in the fridge for up to 3 months. So for comparison, for Moderna, it's about 30 days in that temperature range, and for Pfizer, it's 5 days. So quite a big difference, which is really nice. Okay, next slide, please. Okay, so we're going to get into some of the common questions, which I believe will address a few of these questions that have come through and being posted. And just a quick note, I know there's some questions around, well, when will my office staff get their vaccine? When will family physicians get the vaccine? And we're not going to get into all that right now in terms of the operations. It's going to be the topic of another webinar in terms of the exact rollout. Right now, we're mostly focusing on the vaccine hesitancy piece and communications, but there will, of course, be follow-up communications around this, and we are kind of undergoing the whole prioritization of healthcare workers and the like. Okay, next slide, please. Okay, so one thing that's come up as sort of a unique challenge is trying to explain to clients and everybody the whole piece around what is mRNA technology and what are some things that you want to emphasize when you might be talking to clients who have questions about this. So our communications team is actually in the process of making a really nice video that's aimed at the general public, not explaining things in very technical terms, and that should be posted very shortly to york.ca/COVID-19 vaccine, which is a good resource to refer your patients to. So just took some of the language out of there in terms of a way for you to explain to your clients what the mRNA technology actually is and how it works. A few things that I think are really important, because people are a little bit nervous around the newness of the technology. So a couple of points that you as a provider could use to sort of discuss this a little bit more with your clients is that in and of itself, it's not completely new, like it is in terms of its application to vaccines, but it has been used in other treatment modalities, as you might know. Another thing to emphasize is that it's not actually a live or inactive virus. It just provides that mRNA, which breaks down, is not stable, and doesn't incorporate into the nucleus of the cell, but is actually degraded pretty quickly after entry. And then that mRNA, the patient cell who's getting the vaccine, its machinery and cells are used to make the protein, and then that elicits the immune response that allows protection for any future introduction of COVID-19 virus. So it is important to emphasize that it's broken down, it doesn't go anywhere near the nucleus of the cell, and it's not actually a live vaccine. And so newer technology in terms of applicability to vaccines, but in general people have had experience with mRNA technology before. Next slide, please. Okay, so talking a little bit about efficacy and how it actually works. I think this is a big selling point when you are counseling clients around benefits of vaccines. So both Pfizer and Moderna, and like I said, the Johnson & Johnson that's coming down the pipe soon, hopefully, are very effective. So we're talking 94, 95% effective. Important to know that the primary endpoint when they're talking about efficacy for Pfizer and Moderna is really symptomatic COVID-19 disease. So also being transparent in terms of what we don't know is whether it prevents asymptomatic COVID-19 infection. That remains to be seen. The Pfizer trials did have a bit of a descriptive analysis included, and it did seem to show that it protected against asymptomatic infection, but the numbers enrolled in the trial, that kind of thing, was not large enough to make that determination. So more studies are underway, but it looks promising, at least for Pfizer. But we don't truly know about asymptomatic infection and what the vaccine does in terms of transmission, because we know that you can transmit as an asymptomatic carrier. But again, good news that the efficacy is quite good. The other thing we don't necessarily know is people who already had COVID weren't included in great numbers in the trials. So we don't truly know how effective it is in people who've already had COVID-19 infection. It's thought to be, but that needs more teasing out because not too many people were included. A question that comes up quite a bit about efficacy from providers, so just answering this now, is like, what is the efficacy after one dose? And it is thought to be in the 90s after about 2 weeks of the first dose, but we don't know duration of that protection. So that's the other issue. We do know there's a boosting effect after a second dose, so that's why it's still recommended as 2 doses. And we know more about duration after 2 doses, but we don't know duration after 1 dose. So that's been something that needs to be teased out a little bit more. The other thing, and we'll get into different subpopulations as well, but it is similarly effective in sort of adults with 1 or more comorbidities, as well as sort of in younger adults and older adults. Again, what we don't really know is people in very advanced age, how effective it is in people 85 years of age and older. There weren't too many study participants that met that criteria, and efficacy of residents in long-term care facilities, because there weren't that many in the eligibility criteria of that study either. And then duration again remains sort of in question, but the trials did follow people for different endpoints, about a month after second dose for the Pfizer trials and 3 months after the second dose in the Moderna trials. Okay, and then yeah, quick note on the UK and I guess South African variant. Obviously, this is an area of active research right now, but from what most of the experts seem to be saying, so looking at the different genetic mutations in the South African and UK variant and the actual mRNA, it doesn't seem that it would not be effective, but more research is underway. So that's another area to be a bit more transparent about. Next slide, please. Okay, so one of the things that comes up a lot that we hear from the public all the time is this concern around the approval process really being rushed. So a few things that are helpful to sort of point out when you're speaking to clients about this whole process of approvals is that Canada actually has a very robust system of pharmacovigilance. So every vaccine is monitored very closely. A lot of sort of robust info goes into determining approvals. And there's surveillance both pre-marketing, during the marketing stage, and post-marketing. So pre-marketing, there's a lot of the phase 1, phase 2, phase 3 trials, all that data is submitted to Health Canada, reviewed by Health Canada before it's being approved. Health Canada also kind of goes to the vaccine manufacturer, does some general compliance inspections as well. So there's a lot of that goes on in the back end there also. When it comes to the COVID-19 vaccines and the approval process, there were some changes made to the regulatory process around that, mostly to make it more efficient. So allowing some duplication or kind of crossover between phase 1 and phase 2 trials. So some of that can happen actually at the same time. That was one reason. And then another big reason that's important to talk about is because this vaccine uses mRNA technology, you're not sort of in a lab manufacturing sort of the antigen and things like that, but the mRNA is actually a very quick thing to scale up and mass produce. So that's the other reason, is just by virtue of the technology, it's quite a bit faster. So yeah, that manufacturing times, combined phases, like I said, as well. The other thing to note is just with the marketing phase, there's a lot of surveillance as well. So people having to submit sort of safety reports, risk management plans, all that's ongoing for regular vaccines. And then post-marketing, which we'll get into in the next section, there is a robust system of both passive surveillance, where providers and the public and public health report in adverse events following immunization. So all that is actually tracked. And now there will be an active surveillance system as well, where experts go in and actually interview people who have had the vaccine. Dr. Mirani will be talking about that later. So next slide, please. Okay, so I've already had COVID-19, and I know this was a question in the chat as well for a patient who was COVID positive. How long should they wait till they get the vaccine? So you've already had COVID-19, do you still get the vaccine? So yes, the NACI statement, most up-to-date statements, which we have links to at the end, says that those who have had COVID should be offered a complete series. We know that reinfection is possible, so hence the recommendation. They've also said that in the context of very limited supply, that you would maybe prioritize doses for people who haven't had COVID, particularly if they've had recent COVID in the past 3 months, because reinfection is thought to be quite rare 3 months after you've gotten COVID. So, you might see in later rollout or something prioritizing people who haven't had it in the past, and that's for the reason. And again, there's not that great data on efficacy in people who have had it compared to those who haven't, because they weren't too represented in the studies. But please do note that you don't need to test for COVID before getting the vaccine. You don't need to do serology or anything like that. So yeah, and I guess the other thing to note is if you actively have COVID and are symptomatic, we don't want people who are currently symptomatic to be getting the vaccine, because it'll impact things like adverse events and management of that. So we're asking that people are well before getting the vaccine. Okay, next slide, please. So after I've been vaccinated, can I still get COVID? So an important thing to point out, obviously, is that both the Moderna and the Pfizer are quite effective in preventing symptomatic disease. We don't know, again, too much about asymptomatic, though promising results there from Pfizer, like I said. And we don't know necessarily about the transmission. So currently, the provincial guidance when it comes to managing sort of case and contacts is if you are symptomatic, the recommendation to get tested for COVID-19 still applies, whether or not you've gotten the vaccine. And testing, or the vaccine, should not interfere at all with testing. So if you're doing an NP swab or even the rapid antigen testing, having the vaccine or having had the vaccine should not influence that at all, because it's not a live vaccine or not even an inactivated one. But we are for now still recommending that if people have been immunized, but they've been exposed as a close contact or they're symptomatic, that they still get tested. A lot of the times the side effects, which we'll talk about, are greater after the second dose, and we also know that protection is quite high after the second dose. So when you're seeing a patient and you're trying to risk assess, kind of unlikely that if they have a symptom that it's actually COVID compared to an adverse event after the second dose, but still sort of saying to follow public health advice, and we'll keep an eye out in case the ministry's guidance on that changes. But right now, that's the advice. Okay, next slide, please. Right, so what percentage of the population? So this question comes up quite a lot in terms of the proportion needed to vaccinate to achieve herd immunity. So herd immunity is, as you know, basically the indirect protection from an infectious disease that happens when a population is either immune because of vaccine or because they've gotten the disease from naturally. And we would prefer they achieve that through vaccine because it's much safer, of course. And then this proportion that needs to be vaccinated, it really depends on the R0 number and how effective the vaccine is. So there's not an exact number that's really been described here. There have been several experts, so actually Fauci had a video on this, and there's been some Lancet publications around it. And most of the estimates using, what we think we know about the R0 and of course the efficacy of both Pfizer and Moderna seem to suggest that between 70 to 95%, or sorry, 75 to 90% of the population would need to be immunized to achieve herd immunity. So we do have a little bit of ways to go, because from what you saw from the public opinion polls, we're at about 60% of people that for sure would be sort of gung-ho about taking this vaccine. So definitely some work on public health's end and individual providers when counseling to sort of reinforce that. Okay, so next slide, please. All right, so the question here is around when can you stop wearing a mask and keeping distance from others after receiving the vaccine? So we know that there is good effectiveness here, but we don't know about asymptomatic infection. We don't know exactly about transmission. Rollout is happening over some time. So right now the advice, and I imagine it will continue to be, that you maintain distancing from other people, still follow public health recommendations in terms of the regulations of what's allowed and not. Again, getting tested, isolating if you're a close contact, all those things remain very important and still very fundamental. I imagine as time goes on, we're talking sort of months and months out, that the guidance might evolve in this area as well, depending on what we're seeing community transmission wise. But for now, it's the same public health messaging for very good reasons, and that's reflected as well in the most recent NACI statement. Okay, so just before I turn it over to Dr. Mirani, I'm just going to do a quick scan to see if I can answer some quick questions that are coming up. So somebody's asked, asymptomatic carriers are infected, therefore does not need vaccine at the moment. But what if this asymptomatic carrier does not know they're a carrier and goes ahead and gets the vaccine? How effective will it be? Yeah, so that's totally fine. If you're screening people for symptoms, so those that are well would get the vaccine. If you happen to be COVID positive, that's okay. They still think there'll be good protection, and it is recommended for people, even who have had the infection in the past. But again, the main thing here is that the people who previously had COVID-19 were not included in the studies, so don't truly know about effectiveness, but it is thought to be effective sort of from a theoretical standpoint. So that's quite okay. And again, just to reinforce, you don't need to test for COVID-19 before administering vaccine. Okay, so some of these are operational. Like I said, I won't be getting into too much detail around that, but we will have follow-up information definitely around the rollout. Okay, and then there's some questions around contraindications if people are on anticoagulants or biologics, chemotherapy, low platelets. So we are going to get into special populations and can address a lot of that at that time, but we'll keep that up there just to make sure we've covered off some of those subgroups and can come back to it if not. Okay. Okay, and there is a question about how long to wait after other vaccines are received before getting the COVID vaccine. Some people are holding off. So yes, we have a link to the most recent NACI statement throughout the presentation, and that NACI statement does actually speak to this question. And the idea is actually for theoretical reasons, mostly not to co-administer vaccines. And there is a wait period before or after receiving a vaccine and before getting the COVID-19 one, and the other way around. So please do refer to that statement, and I can pull it up too as well to just get that exact number for you. Okay, and a lot of questions around when family physicians will get the vaccine. I don't have that detail at this time. There will definitely be more communications around that. What proportion of congregate setting staff are refusing vaccination? So it's a great question. I don't have an exact number. So in terms of resident uptake in long-term care, like I said, it's around 95%. We are hearing that some staff in congregate settings are refusing, and for a whole bunch of different reasons, but we are working on sort of campaigns, town halls, working predominantly too with priority populations. So low income, racialized groups as well, as part of what's known as the high priority community strategy to target communications, to target efforts in terms of vaccine uptake. Okay, and then there's some questions about if immunocompromised people can receive it, so that will be answered. Okay, so I'm going to stop there just so my colleague has some time to get through her slides as well, and then we'll pick up some of the Q&A after as well. So just turning it over to Dr. Mirani now. Thank you so much.
Thank you, Dr. Garachibella. I'm just going to take a few minutes to look a special look at safety and adverse events, especially since a lot of your questions in regards to safety, and you might be having to answer these questions when it comes to your patients. Next slide, please. So are the COVID-19 vaccines safe, and how do we know? As healthcare providers, I think we need to be incredibly consistent when it comes to our messaging around safety. And as Dr. Garachibella mentioned earlier, vaccines are tightly regulated and closely monitored in Canada. Health Canada will only approve a vaccine that is safe for widespread use. And certainly there's been a lot of interest and concern behind the mRNA technology. And once again, RNA is a very unstable molecule which is degraded rapidly by your body. It's not going to be absorbed into your DNA. So this means that your body quickly reacts to the vaccine prompt and eliminates the ingredients. After a few days, only your immune response remains. And once again, when it comes to speaking to your patients, you want to emphasize that both the Pfizer and Moderna vaccines have undergone large clinical trials. So the Pfizer trial had about 45,000 participants, and Moderna trial had over 30,000. And this is in addition to all those people who have been vaccinated around the world, right? So in terms of data, we definitely have a large number of people who have been vaccinated and who are currently being monitored. However, if you do continue to get questions about this, you could refer patients to the Health Canada website, updated weekly in regards to adverse events of the COVID-19 vaccines, and Public Health Ontario website as well in regards to vaccine safety. For sort of, you'll know this information is accurate, can't really always speak to what's being shared outside in terms of the safety of these vaccines and what may have potentially happened elsewhere. Next slide, please. So what are the common side effects of the vaccine? This is probably something we should, as healthcare providers, become familiar with. So when it comes to Pfizer, pain at the injection site, fatigue, headache, muscle pain, chills, joint pain, and fever were all listed as common side effects, and similar with the Moderna vaccine. You might come across phone calls or in-person assessments in regards to the side effects from the vaccine, so certainly you can provide that reassurance that that is common. You might have if you have healthcare providers as your patients, there is a link at the bottom of the slide from the ministry which talks about how to manage healthcare workers with symptoms within 48 hours of receiving the COVID-19 vaccine. And we've also attached the COVID-19 vaccine aftercare sheet, just so that you feel confident when it comes to managing side effects. Next slide, please. So with that said, we are aware that this is a new vaccine. So what if there's an adverse reaction from the vaccine? So certainly you want to advise your patients to contact you or your team if they experience an adverse event of event after the vaccine. And so what is an adverse event really? And so we're looking at an unwanted or an unexpected health effect that happens after someone receives a vaccine, which may or may not be caused by the vaccine, right? So if you feel that this needs to be brought to the attention of York Region Public Health, this is the form that you can complete and fax to York Region. And certainly if you need more information, can visit the COVID-19 information for health professionals. Next slide, please. So Canada, again, re-emphasizing the safety surveillance that's happening. Canada has a robust post-marketing safety surveillance program. So passive surveillance certainly comes from you all by reporting any adverse events. But again, there's active surveillance happening under the Canadian National Vaccine Safety Network. And there are, if you need to consult, clinicians available through the Special Immunization Clinic Network, and that has recently expanded to include additional sites in Ottawa and Toronto. Next slide, please. So we're going to briefly touch on special populations. Next slide. So how effective is the vaccine for seniors? So seniors were in fact included in the trials for both Pfizer and Moderna. When it comes to Pfizer, the efficacy is very similar to the younger age group, with in fact older patients experiencing slightly fewer side effects like local reactions and body aches. In Moderna, the vaccine trials also include individuals over age 65, and the efficacy was 86.4%, similar to the younger age group, and older patients again experienced slightly fewer side effects. If you have patients asking questions, especially seniors living in the community, they are to be immunized in phase 2. And as Dr. Karachiwala mentioned, there'll be more information coming out behind the operations of the vaccine administration. Next slide, please. So is the vaccine available for children? So currently the COVID-19 vaccines approved by Health Canada are not intended for children. So the Pfizer one has been approved for people 16 years of age or older, and the Moderna COVID-19 vaccine has been approved for people 18 years of age and older. Its safety and effectiveness in people younger than 18 years of age has not yet been established. So at this time, COVID-19 vaccine for children is not currently available, and a timeline for when a COVID-19 vaccine for children will be available has not yet been announced. Next slide, please. So you might have already gotten a lot of questions about this group. So is the vaccine safe for pregnant and breastfeeding? And if you review the NACI statement or the Society of Obstetricians Gynecology statement and the Ministry of Health, they're pretty much all saying the same. So women who are pregnant or breastfeeding should be offered the vaccination at any time if they're eligible and no contraindications exist. A lot of the concern, of course, comes from the fact that this group was not included in the Pfizer or Moderna studies. And so, of course, being honest about that and upfront with your patients that we don't have that information. So certainly, if a patient is asking for more information, the decision to get the vaccine is based on the patient's personal values and understanding that there is this theoretical risk, but really needing to think about if in this case, the risks of getting COVID-19 certainly versus getting the vaccine, and which outweighs the benefits, which outweighs which. So generally the advice is women should not be precluded from vaccination based on pregnancy status or breastfeeding. Next slide, please. Is the vaccine safe for people who are immunosuppressed because of disease or treatment? Again, similar to the population of women who are pregnant, immunosuppressed individuals were not included in the trials. So at this point, the vaccine can be offered. Again, it's a bit of a risk assessment to deem that the benefits outweigh the risk. And as long as there's informed consent and around the lack of evidence in this population, that the vaccine can be given to individuals. So this includes individuals with autoimmune conditions, immunodeficiency conditions, those immunosuppressed due to disease or treatment, as long as they have been canceled. And so certainly if there's questions, you can reach out to their specialists if you need further advice. Next slide, please. can I get the vaccine if I have an egg or another allergy? And again, in the past, certain vaccines have included the egg protein, which may explain this concern. The list of ingredients for the Pfizer and Moderna vaccine does not list egg protein as an ingredient. So therefore, the only contraindication for anyone for COVID-19 vaccine is anyone with a severe or immediate reaction or anaphylaxis to any component of the vaccine. So if there is any concern, at this time the ministry does recommend reaching out to potentially an allergist or immunologist who might have who can do a risk assessment in this scenario. If the patient has a food or another medication allergy, vaccine can be offered. But again, so the only contraindication at this time is the fact that if someone has a severe or immediate reaction to any component of the vaccine, for which if you need more advice, certainly feel free to reach out to an allergist for more information. Next slide, please. I don't know if my religious beliefs allow me to get vaccinated. So some patients may have questions regarding their religion in receiving COVID-19 vaccines. You can assure them that the COVID-19 vaccines do not contain any food products or gelatin and are recommended or permissible by many religious organizations. In fact, many religious organizations have issued statements that encourage the COVID-19 vaccination for the health and safety of individuals. And we've listed a few here for your reading if you'd like. Next slide. So just to conclude, some key messages. So as healthcare providers, we certainly need to feel confident when it comes to the safety and administration of these vaccines. So please, reiterate to your patients that the standards of safety, efficacy, and quality have not been compromised to expedite the approval of COVID-19 vaccines. Health Canada oversight of COVID-19 vaccines will certainly not stop at just approval. So Health Canada continues to monitor the vaccine safety and effectiveness now and in the future. And in regards to the research into the value of mRNA for vaccinations, this has been progressing for over 10 years. So though the new vaccine is the first mRNA vaccine approved for use in humans, mRNA has been successfully used in cancer treatments. Next slide, please. So thank you. So I'll pass it back to Dr. Karachiwala to answer some of your questions. Thank you.
Thank you so much. Okie dokie, a whole bunch of questions coming through on the live Q&A, which is great. So I will try to hammer some of these out. Okay, so I just want to get back to the one around vaccine co-administration, just to give you an exact time frame. So the most up-to-date NACI statement that was released on January 12th says that if you've gotten the COVID vaccine, it's prudent to wait 28 days, so 4 weeks, before getting another vaccine. Now, the only exception to this is anything to do with post-exposure prophylaxis. So if we end up with like a measles case or outbreak, which knock on wood we don't, and you have to get that for post-exposure prophylaxis, that is okay. Same thing would apply for something like hepatitis A if there is again an outbreak and more people are thought post-exposure to be vaccinated. And then if you have gotten another vaccine and are waiting for your COVID vaccine, NACI says prudent to wait 14 days. Just to answer that one. Okay, then we have another great question about once all the long-term care folk are immunized, will they stop swabbing weekly? This is a great question. I hope so is my answer. The whole idea around the weekly testing for long-term care and sort of bi-weekly for retirement homes, that was a policy decision by the provincial government. Local health units have had sort of varying success. I think, in some of the studies and outcomes, it's been kind of lower yield when there is not a case or outbreak. So we've been advocating a little bit to the government to have that be reconsidered in light of sort of lab capacity and things like that. So I'm hoping that, yes, when things change, that might be the direction, but that's sort of in the hands of the folks at the province. But we're all always in sort of communication and providing back and forth input, so hopefully. And then there's a question around booster doses. and whether or not that's going to be required in the future. So sort of after the 2-dose series is complete, whether you need a yearly booster. So that information is not known at this time. The duration, like I said, of some of the studies and the endpoints they've tracked after people are finished are in the range of months. Don't know sort of a year out what that will look like. So as these trials continue, we'll get more information on that and whether it's something like influenza where you need a yearly booster or not. Okay, so and then somebody else has asked what delay is acceptable for getting the second dose. There's been a whole lot of debate and discussion around this point as well, and whether even in terms of the rollout, whether it's prudent to just give everybody a dose, given that we know it's pretty effective after 1 dose, but don't know the duration of protection after just 1 dose, or whether you hold back and give a second dose. The ministry has sort of said to keep kind of a line of sight to the second dose. And the most up-to-date NACI statement, again, that's the one that was released in mid-January, did say that the upper limit of getting the second dose should be around 42 days, and that's based on the studies from both Pfizer and Moderna looked at there was a range of time, and some people got it at the 42-day mark instead of the sort of 21 to 28-day mark. And sort of theoretically speaking, for something like a non-live vaccine, when you give something too late, it's usually okay. The most important thing to respect in vaccinology principles is that minimum interval. So if you give it too early, that's a problem, but usually if you give it too late, not a problem. And they're not recommending if it's late to restart the series or anything like that, but they have specified a time frame of 42 days in an ideal world. Okay. And then I'm seeing some comments around the deaths in Norway. So yeah, it's a really good question. I think people are reading about this in the media. For those that haven't heard, there was reports of, I believe it was actually like 23 deaths in frail elderly people in the sort of long-term care population in Norway. Out of about 42,000 or so that they vaccinated. So yeah, this would cause some concern and questions, rightfully so, from clients. And I would say in terms of explaining this and talking it through, it's important to point out that the population in long-term care and retirement home that are frail or elderly, they tend to have at baseline a higher mortality rate. So just purely by coincidence, you would see a certain number of deaths expected per week regardless. Some of this might be coincidental. That's not to say that there's no degree of causality. I mean, all that's being explored. I think a lot of these, so Norway and Canada, of course, have a very robust system for looking into these adverse events. It goes through multiple levels of government, locally, then provincially, then federally, and then special task forces look at these things to figure out whether it's just coincidence or whether it's causality. So that kind of thing would be very heavily scrutinized. None of these studies showed that type of an adverse event that would have halted the study. That being said, it hadn't been rolled out on a mass level yet. So not that this is a conclusive piece of evidence, and obviously newer vaccine that's still being looked into. But none of those signals popped up in the studies and haven't to date in the rollout of those other places, and that you would expect some degree of fatalities in the long-term care home, but it's being evaluated. So it's sort of a stay tuned type picture as well, with maybe some reassurance. But that being said, there's a lot about COVID and a lot about COVID vaccine that maybe we don't know quite as much in detail. Okay, and then somebody's asked the questions around long-term adverse effects and how do you sort of counsel or reassure your patients around those. So really good questions, because the stuff that we've pointed out here in terms of adverse events, they are more in the short term, and the study endpoints, of course, are, like I said, months out, not years out. So that's sort of info that's to be determined. Trials will be ongoing. And a lot of this is based on, or what's theorized anyways, is based on what we know from non-live vaccines and just vaccinology and key principles. So yeah, I think that will continue to be monitored. And I guess as a plug, that's why APHE reporting is excruciatingly important, because it helps figure out and track any safety signals even years out. So please do continue to report anything that you might see come into you as a provider. Also seeing a question about what about people with sort of chronic conditions who cannot leave their home? How will they get the vaccine? And that's a really good question as well. I think, what we're looking at when it comes to mass vaccination planning is a variety of different models. So in the fall, we tested drive-through models for influenza, looking at more kind of mobile things and whether, there's a possibility of having sort of home care providers also deliver vaccines. So all these different modalities will be looked into, and I think it's going to be a multi-pronged strategy, but definitely recognizing there are some vulnerable people in our communities who can't travel and may need a home-based solution. So that is definitely being considered by our planning teams and being talked about in sort of prioritization. Okie dokie. So a lot of questions too around, maybe I'll just speak to sort of healthcare worker prioritization. So getting a lot of questions on, as a healthcare worker, when might I get the vaccine? When can I be on the list to get it? And a rough time frame. And I know someone's pointed out that the medical officer of Peel, Dr. Lowe, mentioned that it might be sort of a kind of spring time frame. So, I mean, I guess I can tell you just a little bit about how that's working, but since we have some time, so I won't get into too much detail, but essentially it's been a bit of a confusing area and there's multiple parties involved. So local health unit, ministry, Ontario Health. There was a release document around healthcare worker prioritization, which hopefully people have access to. It's on the website as well from the ministry, specifying that public health role will be mostly to prioritize the different sectors and settings. So work is underway to consult about that, to prioritize, to use that ministry framework, see if locally there's anything missing from that. I know some health units have come up with sort of risk criteria or risk scores. So, I mean, looking into that, I don't know if that's the direction that will everyone will go in. And then in terms of like that individual based decision may end up being more towards the actual organization or Ontario Health, whereas we might specify some of the sectors or settings that would be started, like where we would start with. In terms of rough timeline, I mean, it's hard to say. I think phase 1 and phase 2, of course, include sort of these higher risk healthcare workers, and that with the Pfizer delay, I mean, maybe it would be around what Dr. Lowe was saying in sort of spring, summertime for all providers to be vaccinated. I don't know, the supply issues are sort of in the hands mostly of the federal government. So I don't have great line of sight, I guess, into that, but in case that info was helpful around the prioritization still being worked through, will involve consultations though, and definitely more info to come. As soon as we're knowing anything, we will send that out. Okie dokie, just scrolling here. Okay, about how many days after having COVID infection can you get COVID-19 vaccine? So again, if you're feeling well and have had a previous infection, you're still eligible to get the vaccine. NACI is saying if we're really trying to prioritize populations, you might wait 3 months after having COVID-19 to get the vaccine. That's more for our end if we're trying to prioritize groups for getting it. Otherwise, you are eligible even if you've had the infection, just can't be actively symptomatic. Okay, once vaccinated, if someone is a close contact of a case, will 14-day quarantine still be needed? So for now, the answer is yes, at this current time. I imagine this guidance is going to change as we learn more about efficacy, as more of the population, particularly in phase 3, probably is rolled out. But for right now, and probably the short term, the ministry direction on exposure, if you are exposed and isolating, or even if you're symptomatic and needing to get tested, that all remains the same at this point in time. Okay, is there any time when we need to check COVID antibody? So not really. Again, the guidance on this might change. Right now, it's mostly available for hospitalized children who they're contemplating a diagnosis of multi-inflammatory SCIC. That is happening and ordered, but otherwise not routinely available. It's happening in sort of other surveillance capacities as well. After taking both vaccines, does a person returning from travel have to quarantine? Right now, yes, the federal quarantine orders still stand. Again, I imagine at some point this might be adjusted, and they're doing all sorts of pilots to look at shorter days of quarantine, particularly in Alberta, and testing at a certain time frame. But right now, the recommendation is the same of 14 days of quarantine, yes. Okie dokie. All right, well, it's just at 6 o'clock. There are a couple of other ones that we can still address in sort of the written document that we send out after. And like I said, a lot of the operations of it all, we will be sending communications. There will be future webinars directed at primary care, especially getting involved in immunization. So with that, I will say thank you so much for tuning in. Hope this was helpful. If you have any general comments of other topics you want in webinars or other times that might work, we usually have this at noon, but today we had it at 5 to 6, hoping that works with people's schedules. If you have any general concept of when primary care, when providers in the community are more free to listen in, please do type it. We're very open to suggestions. And if you have any quick feedback, even an out of 10 of how this was or whether you would tune in again, please write it in the comments. Again, it is pretty anonymous and not everyone's seeing it, so it'll just go to us and we use it to better our presentations. Thank you so much for tuning in, and hope everyone's keeping well. Thank you so much. Take good care.